Management of acute trauma. Welcome to today's podcast, where we discuss the management of acute trauma. Our conversation is structured in a question and answer format to support medical students, surgical residents, clinicians, and all listeners interested in the management of acute trauma. Pause the podcast after each question to attempt answer. Let's begin. Management of specific injuries. Damage control principles. Question: what is damage control surgery? Answer: damage control surgery is a surgical approach to manage severe injuries by prioritizing life-saving interventions over definitive repair. Question: what does the damage control surgery procedure involve? Answer: the damage control surgery procedure involves expeditious hemostasis, management of contamination, temporary abdominal closure, and transfer to the intensive care unit for resuscitation. Question: where is damage control surgery applied? Answer: damage control surgery was initially used for abdominal injuries, but is now applied to the chest, pelvis, and extremities to control major vascular and organ injuries. Question: how is damage control surgery used in trauma care? Answer: damage control surgery is a surgical approach used in trauma care to stabilize patients with life-threatening injuries by controlling bleeding and contamination, often followed by definitive surgery within 48 hours. Question: what are the risks of damage control surgery? Answer: overuse of damage control surgery can lead to additional surgeries, hernias, fistulas, prolonged ventilation, and delayed nutrition. Question: what is damage control resuscitation? Answer: damage control resuscitation is a resuscitation strategy that involves permissive hypotension, early balanced transfusion, and treatment of coagulopathy to improve survival in severely injured patients. Question: how is thrombolistography applied in trauma care? Answer: thrombolistography is used as adjunctive guidance for the massive transfusion protocol, providing real-time assessment of clot generation. Question: what are the advantages of thrombolistography? Answer: thrombolistography provides rapid results for individualized transfusion, conserves blood products, and may offer a survival benefit. Question: what is the function of tranexamic acid? Answer: tranexamic acid is a synthetic lysine derivative that inhibits fibrinolysis by antagonizing plasmin binding to fibrin surfaces. Management of the open abdomen. Question: what are the potential complications associated with damage control laparotomy? Answer: damage control laparotomy may result in the development of ventral hernias and enteroatmospheric fistulae. Question: what is the principal goal in managing the abdominal wall in patients with an open abdomen? Answer: management of the abdominal wall focuses on achieving primary closure or reducing the size of the hernia. Question: when is it typical to return a patient to the operating room for further management of the open abdomen following the initial laparotomy? Answer: a return to the operating room for additional management is usually planned 24 to 48 hours after the initial laparotomy, but may occur sooner if the patient's physiological condition improves. Injuries to the brain. Traumatic brain injury management. Question: what is the primary goal in the management of traumatic brain injury? Answer: the primary goal is to prevent secondary brain injury and to treat recoverable cells around the area of trauma. Question: what factors should be minimized to prevent secondary brain injury in patients with traumatic brain injury? Answer: all secondary brain injury factors should be minimized, including raised intracranial pressure, decreased cerebral perfusion pressure, low oxygen levels, low blood pressure, high blood pressure, impaired cerebral autoregulation, systemic inflammatory response, seizures, and elevated body temperature. Question: what immediate management steps are critical for a patient with traumatic brain injury? Answer: immediate management should follow standardized advanced trauma life support-based resuscitation, including control of severe uncontrolled bleeding, securing the airway, and providing ventilatory support to prevent low blood pressure and low oxygen levels. Injuries to the spinal cord and the vertebral column. Question: what is the current recommendation regarding immobilization of patients with potential spinal injury? Answer: patients with potential spinal injury are no longer systematically immobilized on long spine boards with cervical collars. Question: what are some negative effects associated with the use of cervical collars? Answer: cervical collars can increase intracranial pressure, reduce mouth opening, alter pharyngeal mechanics, cause discomfort, result in skin injury, obscure wounds, impede swallowing, and increase the risk of aspiration. Question: what are the criteria for applying spinal motion restriction in trauma patients? Answer: spinal motion restriction should be considered for patients who have experienced a fall greater than 3 meters, are older than 65 years, have suffered a serious traumatic injury, or have a traumatic brain injury. Question: how is a gross assessment of spinal cord function performed in trauma patients? Answer: gross assessment of spinal cord function is done by observing extremity movement. Question: what is the recommended procedure for examining the back in patients with suspected spinal injury? Answer: examination of the back should be performed with a log roll maneuver, involving at least 3 people supporting the patient, to inspect the back and perform a digital rectal examination. Question: what are the essential aspects of post-injury care for patients with spinal injury? Answer: post-injury care includes preventing heat loss, frequent reassessment, involvement of a spine surgeon, and avoiding unnecessary imaging to expedite care. Injuries to the maxillofacial region. Question: how common are facial injuries annually in the United States, and what percentage are reported to the National Trauma Data Bank? Answer: over 3 million facial injuries occur every year in the United States, and 25% of these are reported to the National Trauma Data Bank. Question: what are the main mechanisms responsible for maxillofacial injuries? Answer: maxillofacial injuries most commonly result from blunt or penetrating trauma associated with motor vehicle crashes, falls, assaults, and participation in sports. Question: what injuries and complications are commonly associated with trauma to the maxillofacial region? Answer: trauma to the maxillofacial region may be associated with traumatic brain injury, cervical fractures, deficits in vision, olfaction, hearing, and taste, scarring, loss of facial expression, occlusion problems, and impairment of speech. Immediate management. Question: what mechanisms can lead to airway compromise in patients with maxillofacial trauma? Answer: airway compromise can be caused by posterior displacement of maxillary fractures, loss of the tongue insertion point, Foreign body obstruction, bleeding, soft tissue swelling, and injury to the larynx or trachea. Question. What methods are used to control hemorrhage in patients with maxillofacial injuries? Answer. Hemorrhage control is achieved through compression, packing, suture repair, application of topical hemostatic agents, and stabilization of fractures. Question. What are the important considerations in airway management for patients with maxillofacial trauma? Answer. Airway management includes early intubation, having backup airway options such as surgical approaches, and positioning the patient upright to prevent aspiration. Question. What challenges may complicate airway management in patients with maxillofacial trauma? Answer. Airway management may be complicated by supine positioning, facial deformity, and the presence of a jaw fracture in patients with maxillofacial trauma. Question. What are the considerations for administering medications to awake patients with potentially difficult airways? Answer. Administering medications to an awake patient with a potentially difficult airway requires experienced personnel and careful consideration. Question. Why is cervical spine motion restriction often required and how does it impact airway management? Answer. Cervical spine motion restriction is frequently necessary in maxillofacial trauma patients, and it can further complicate airway management. Evaluation question. What steps are involved in the assessment of facial injuries? Answer. Assessment of facial injuries involves physical examination, evaluation of the eyes for vision changes, inspection of the orbit, examination of the ear, and assessment of the stability of the midface and mandible. Question. What imaging techniques are commonly used for evaluating facial injuries, and in which situations are they especially indicated? Answer. Three-dimensional computed tomography imaging is frequently used to visualize facial bones and assess soft tissue, especially when there is severe external injury or facial abnormality. Question. What structural features support the facial skeleton, and what are the possible locations of frontal sinus fractures? Answer. The facial skeleton is supported by 4 paired vertical and 4 horizontal buttresses. Frontal sinus fractures may involve the anterior wall, posterior wall, or both. Question. What bones are affected in zygomatico-maxillary complex fractures, and what are the possible consequences? Answer. Zygomatico-maxillary complex fractures involve the temporal, sphenoid, maxilla, and frontal bones, which can lead to enophthalmos and may require surgical intervention. Question. How are Lefort fractures classified, and which facial structures do they affect? Answer. Lefort fractures are classified into 3 types based on the fracture line and involve different facial structures, ranging from the maxilla to craniofacial dissociation. Question. What are the risks and management priorities for orbital fractures? Answer. Orbital fractures can lead to ocular injuries and require prompt evaluation and intervention to prevent vision loss. Management question. What are the immediate priorities in managing facial fractures and severe soft tissue injury? Answer. The immediate priorities are airway management and bleeding control when managing facial fractures and severe soft tissue injuries. Question. What are the key steps in wound management for facial trauma, and which areas require special attention? Answer. Wound management involves debridement, irrigation, and closure of lacerations, with special attention required for injuries to the lip, nose, ear, and orbit. Question. How is the urgency of facial fracture management determined, and which types require immediate intervention? Answer. Urgency in the management of facial fractures depends on the severity. Severely depressed fractures require urgent attention, while other fractures can be managed later. Injuries to the neck question. Is neck trauma common, and how does its mortality rate compare to other body regions? Answer. Neck trauma is relatively uncommon but has the highest mortality rate among all body regions. Question. What are the common mechanisms of neck injury? Answer. The most common mechanisms are penetrating injuries such as gunshot and stab wounds, followed by blunt force trauma. Question. What types of injuries can occur with neck trauma? Answer. Neck trauma can cause direct lacerations to vascular and aerodigestive structures, fractures of the larynx or trachea, blunt pharyngeal or esophageal injuries, and blunt cerebrovascular injuries. Immediate management question. What are the initial management priorities for neck trauma? Answer. The initial priorities are to control life-threatening hemorrhage and to establish a secure airway. Question. When is immediate intubation indicated in neck trauma patients? Answer. Immediate intubation is crucial for patients with expanding neck hematemas or potential airway compromise. Question. How are carotid sheath vasculature injuries best treated? Answer. Surgical control is often the optimal treatment for carotid sheath vasculature injuries, with concurrent massive transfusion protocol-based resuscitation if needed. Question. What are the signs of carotid artery injury? Answer. Signs of carotid artery injury include bruising, swelling, and facial asymmetry. Question. Can cervical spine injury result from both blunt and penetrating trauma? Answer. Yes. Cervical spine injury can result from either blunt or penetrating trauma. Question. Should a cervical collar be placed empirically in penetrating neck injury? Answer. Empiric placement is not needed, and any existing collar should be removed for thorough neck evaluation. Evaluation question. What does the neck contain, and how is it protected? Answer. The neck contains vital structures in a small area, and these structures are mostly protected by soft tissue. Question. How are penetrating neck injuries usually described? Answer. Penetrating neck injuries are usually described by the anatomic zone in which they occur. Question. What is zone 1 of the neck? Answer. Zone 1 refers to the area between the clavicles and the cricoid cartilage. Question. What is zone 2 of the neck, and why is it important? Answer. Zone 2 is the area from the cricoid cartilage to the angle of the mandible and is the most surgically accessible region of the neck. Question. Where is zone 3 of the neck located? Answer. Zone 3 is located from the angle of the mandible to the base of the skull and is the least surgically accessible zone. Question. When is immediate surgical intervention required for neck injuries? Answer. Immediate surgical intervention is required for patients with hemodynamic instability or hard signs of vascular or aerodigestive injury. Question. What imaging methods are used for evaluating thoracic and neck injuries? Answer. Rapid bedside chest X-ray and extended focused assessment with sonography for trauma, EFAST, are helpful for thoracic evaluation, while thin slice multi-detector computed tomography angiography is used for further evaluation of neck injuries in stable patients. Question. How are aerodigestive and laryngeal tracheal injuries diagnosed in neck trauma? Answer. Contrast studies with gastrographin or thin barium, along with esophagoscopy, can diagnose aerodigestive injuries. Laryngoscopy or bronchoscopy are used for laryngeal or tracheal injuries in symptomatic patients. Question: how are the different neck injury zones managed surgically? Answer: Zone 1 injuries are surgically approachable but require various incisions. Zone 2 injuries are easily exposed through a standard oblique cervical incision, while Zone 3 is difficult to access with open surgery. Question: what is the management approach for Zone 2 injuries with hard signs? Answer: hard signs of vascular or aerodigestive injury in Zone 2 require immediate operation, while other cases may undergo radiographic assessment. Question: how is hemorrhage controlled in neck trauma patients? Answer: hemorrhage is controlled with manual compression or balloon tamponade, and catheter-based interventions are preferred, even in unstable patients. Question: what is the accuracy of computed tomography angiography for detecting vascular or aerodigestive injuries? Answer: computed tomography angiography has a sensitivity of 100% and a specificity of 97.5% for detecting penetrating vascular or aerodigestive injuries. Question: what are the advantages of multi-detector computed tomography angiography in neck trauma evaluation? Answer: multi-detector computed tomography angiography allows for comprehensive neck evaluation and may reduce the need for additional invasive tests such as bronchoscopy or angiography. Question: how should patients with equivocal multi-detector computed tomography angiography results be further evaluated? Answer: patients with uncertain multi-detector computed tomography angiography results, such as those with retained ballistics, may benefit from further selective diagnostics like digital subtraction angiography. Question: what causes blunt cerebrovascular injury in neck trauma? Answer: blunt cerebrovascular injury can be caused by seatbelt compression or flexion extension mechanisms. Question: what is the range of severity for blunt cerebrovascular injury? Answer: the severity ranges from intimal tears to full thickness injury with pseudoaneurysm formation or transection. Question: what is the preferred method for diagnosing blunt cerebrovascular injuries? Answer: multi-detector computed tomography angiography is the study of choice for diagnosing blunt cerebrovascular injuries, with screening criteria including injury above the clavicle, unexplained neurologic findings, and Horner syndrome. Management question: when is neck exploration indicated in trauma patients? Answer: neck exploration is indicated when there are hard signs of vascular or aerodigestive injury. Question: what is the typical surgical approach for neck exploration? Answer: the typical approach involves an incision along the sternocleidomastoid muscle to expose the carotid sheath and its contents. Question: how are vascular injuries of the neck managed? Answer: injured veins are either repaired or ligated, and carotid artery injuries are managed according to severity, ranging from simple closure to reconstruction. Question: what steps are involved in managing esophageal injuries in neck trauma? Answer: management includes debridement of the esophageal wall, closure in 1 or 2 layers, external drainage, and possibly vascularized muscle pedicle coverage. Question: what are the challenges in managing esophageal injuries, and how are they addressed? Answer: massive tissue loss or delayed presentation may require esophageal diversion with esophagostomy and delayed reconstruction. Question: how are tracheal injuries managed in neck trauma? Answer: small lacerations can be closed primarily, large defects may require resection and anastomosis, and some anterior injuries can be managed with tracheostomy. Question: what treatments are recommended for blunt cerebrovascular injury in the neck? Answer: antiplatelet or anticoagulation therapy is recommended, and endovascular stenting may be considered in specific cases. Question: when should treatment for blunt cerebrovascular injury be started, even if there is a risk of bleeding? Answer: treatment should be started as soon as safely possible, since most strokes occur within the first few days after injury, even if there is a risk of bleeding. Question: why is follow-up imaging important in neck trauma, and what is the recommended schedule? Answer: repeat imaging at 7 to 10 days is important to evaluate for progression or resolution and guide therapy discontinuation. Persistent injuries may require antiplatelet treatment for 3 months with serial outpatient multi-detector computed tomography angiography. Injuries to the chest. Question: how common are blunt and penetrating chest injuries, and what are their typical causes? Answer: blunt and penetrating chest injuries are common, often occurring in patients with multiple injuries, with falls and motor vehicle collisions being frequent causes. Question: why is the chest particularly vulnerable to trauma, and what injuries can result? Answer: the chest's prominent position makes it susceptible to both blunt and penetrating trauma, which can potentially lead to lung contusions. Question: do isolated chest injuries frequently require urgent surgery, and how does the need for surgery differ between penetrating and blunt trauma? Answer: isolated chest injuries rarely necessitate urgent surgery, but penetrating trauma has a higher surgical rate compared to blunt trauma. Immediate management. Question: what should be addressed immediately in thoracic injuries, and what conditions must be evaluated? Answer: immediate management of thoracic injuries focuses on addressing pulmonary compromise and physiologic derangement by evaluating for pneumothorax or tension pneumothorax. Question: how should external hemorrhage be managed in chest trauma? Answer: external hemorrhage should be controlled with direct pressure, and resuscitation should be initiated. Question: when is operative intervention indicated in patients with chest trauma? Answer: operative intervention may be indicated for persistent shock despite resuscitation and tube thoracostomy with ongoing blood loss. Evaluation. Question: how are chest injuries diagnosed? Answer: chest injuries are diagnosed using physical examination and chest radiography. Question: when is chest radiography performed in trauma patients, and what is its purpose? Answer: chest radiography is performed during the primary survey in patients at risk for thoracic injuries to evaluate for pneumothorax or hemothorax. Question: what imaging modality is the standard for evaluating the chest in trauma, and why? Answer: thoracic multi-detector computed tomography angiography is the standard approach because it provides excellent visualization of the chest wall anatomy, vasculature, pleural spaces, and lung parenchyma. Question: what diagnostic modalities are recommended for penetrating chest trauma? Answer: multi-detector computed tomography angiography for great vessels, bronchoscopy for airways, and esophagoscopy with contrast esophagography for the esophagus are recommended. Question: what can lead to false negative results in the evaluation of hemothorax? Answer: decompression into a hemothorax can lead to false negative results. Question: how can the diagnostic sensitivity for chest injuries be maximized? Answer: diagnostic sensitivity approach is 100% when multiple complementary studies are performed. Management. Question: how are most thoracic injuries managed, and what technique is preferred for emergent cases? Answer: the majority of thoracic thoracic injuries are treated with a single-tube thoracostomy, and the open technique is preferred because it is safe and rapid for emergent cases. Question: what are the steps involved in an open thoracostomy procedure? Answer: the open thoracostomy procedure involves performing a sterile procedure, making an incision in the triangle of safety at the 4th to 5th intercostal spaces, blunt entry into the thoracic cavity, and apical chest tube placement. Question: what size chest tubes are traditionally used, and how do percutaneous catheters compare? Answer: traditionally, 32 to 36 French chest tubes are used, but 14 French percutaneous catheters show equivalent success and decreased morbidity. Question: what are the traditional indications for emergent thoracotomy and chest trauma? Answer: traditional indications for emergent thoracotomy include massive blood loss, persistent drainage, and hemodynamic instability. Question: how do surgeons decide whether thoracotomy is necessary in chest trauma patients? Answer: surgeons assess clinical presentation, physiology, and response to resuscitation to determine the need for thoracotomy. Question: what additional conditions may require thoracotomy in chest trauma? Answer: massive air leak with pneumothorax and drainage of esophageal or gastric contents from the chest tube may also necessitate thoracotomy. Question: how is the surgical approach selected for thoracotomy in chest trauma? Answer: the surgical approach for thoracotomy depends on the suspected injury. Question: what does a posterolateral thoracotomy provide access to in chest trauma surgery? Answer: a posterolateral thoracotomy provides access to the lungs, pulmonary vasculature, hemidiaphragm, esophagus, trachea, and mainstem bronchi. Question: what structures can be accessed through a median sternotomy in chest trauma patients? Answer: a median sternotomy offers versatile access to the right side of the heart, ascending aorta, aortic arch, and pulmonary vasculature, chest wall and pleural space injuries. Question: what is the most common thoracic injury, and how prevalent are rib fractures among trauma admissions? Answer: chest wall injuries are the most common thoracic injury, with rib fractures occurring in approximately 10% of trauma admissions. Question: what are the typical causes of rib fractures? Answer: rib fractures typically occur due to high energy impacts to the chest, such as motor vehicle collisions or falls from height. Question: what can result from a large amount of energy being transferred to the chest? Answer: large amounts of energy transferred to the chest can result in a flail segment, which often leads to a significant pulmonary contusion. Question: how can injuries to the chest wall and pleural space be identified radiographically? Answer: chest radiographs can identify injuries to the chest wall and pleural space, with pneumothorax appearing as lucency and hemothorax as dependent opacification. Question: what advantages does chest computed tomography provide in evaluating chest wall injuries? Answer: chest computed tomography provides a more sensitive and specific evaluation, diagnosing chest wall deformities like flail segment, displaced ribs, and sternal fractures. Question: how can an occult pneumothorax be detected? Answer: chest computed tomography can identify occult pneumothorax, which is not visible on plain radiography. Question: what should be considered for all pneumothoraces and hemothoraces visible on a chest radiograph? Answer: all pneumothoraces and hemothoraces visible on a chest radiograph should be considered for tube thoracostomy. Question: when is observation considered safe for pneumothoraces? Answer: observation may be safe for blunt end penetrating pneumothoraces with a computed tomography radial diameter of up to 35 mm in the absence of hemodynamic instability and respiratory compromise. Question: how can asymptomatic pneumothoraces without respiratory compromise be managed? Answer: asymptomatic pneumothoraces not accompanied by respiratory compromise can be managed with observation and a repeated chest radiograph in 12 to 24 hours to demonstrate stability. Question: what is the approximate volume of hemothoraces visible on an upright chest X-ray? Answer: hemothoraces visible on upright chest X-ray represent an approximate volume of 400 to 500 milliliters. Question: what is the recommended management for hemothorax, and how can the incidence of retained hemothorax be reduced? Answer: evacuation with tube thoracostomy is recommended, and immediate irrigation of the thoracic cavity after tube insertion can reduce the incidence of retained hemothorax. Question: what intervention should be considered for residual hemothorax that does not resolve after chest tube placement? Answer: residual hemothorax that does not resolve after chest tube placement should be considered for video-assisted thoracoscopic surgery for hematoma evacuation to prevent complications like trapped lung and emphysema. Question: how does the impact of rib fractures vary among patients? Answer: the impact of rib fractures varies based on injury and patient characteristics, potentially leading to respiratory issues. Question: why is pain management crucial in patients with rib fractures, and what approaches are commonly used? Answer: pain management is crucial for optimal pulmonary hygiene, often involving multimodal approaches and acute pain services. Question: what is the significance of rib fracture location in thoracic trauma? Answer: upper rib fractures, specifically ribs 1 to 3, are linked to thoracic vascular injuries, while lower rib fractures, specifically ribs 9 to 12, are associated with intra-abdominal organ injuries. Question: what is rib score and how does it assist in thoracic trauma care? Answer: rib score is a scoring system that quantifies rib fracture injury based on radiographic measures, predicting adverse pulmonary outcomes and guiding patient disposition. Question: what is the SCARF score and how is it used in critically ill patients? Answer: the SCARF score is another scoring model using repeated clinical measurements to predict adverse outcomes in critically ill patients. Question: what are the benefits of surgical stabilization of rib fractures? Answer: surgical stabilization provides pain relief, decreases the duration of mechanical ventilation, reduces intensive care unit and hospital length of stay, and decreases the incidence of pneumonia. Question: what are the risks associated with surgical stabilization of rib fractures? Answer: risks include wound complications, device-related complications, and infections. Question: why is patient selection important for surgical fixation of rib fractures? Answer: patient selection is critical for optimal outcomes, as surgical fixation may not be beneficial for all patients with rib fractures. Pulmonary injuries. Question: what is a lung contusion? Answer: a lung contusion is tissue damage and bleeding in the lungs caused by direct or indirect chest trauma. Question: how severe can lung contusions be? Answer: lung contusions can range from mild to severe, and in severe cases, may lead to respiratory failure. Question: how are lung contusions diagnosed? Answer: lung contusions are often first identified on chest X-rays, with computed tomography scans providing more detailed information. Question: what is the recommended management of pulmonary contusions? Answer: supportive care is recommended and includes maintaining pulmonary hygiene, providing pain control, and monitoring for respiratory decompensation. Question: what treatment may be necessary in severe cases of pulmonary contusion? Answer: in severe cases, mechanical ventilatory support or extracorporeal membrane oxygenation may be necessary. Question: what is the survival rate for trauma patients undergoing extracorporeal membrane oxygenation? Answer: the survival rate to discharge is 61% for trauma patients undergoing extracorporeal membrane oxygenation cannulation, according to a large analysis of the Extracorporeal Life Support Organization registry. Question: what are the primary treatments for thoracic trauma? Answer: the primary treatments for thoracic trauma are non-operative measures and tube thoracostomy. Question: how effective is tube thoracostomy for thoracic trauma? Answer: tube thoracostomy effectively manages low-pressure lung bleeding and small air leaks in most cases. Question: what does persistent bloody output from a chest tube indicate? Answer: persistent bloody output suggests a more serious source of bleeding, potentially requiring further intervention. Question: which procedures are more commonly used to control bleeding in penetrating thoracic trauma? Answer: staple tractotomy and wedge resection are more commonly used procedures for bleeding control in penetrating thoracic trauma. Question: what procedures are more common for bleeding control in blunt thoracic trauma when resection is indicated? Answer: anatomic lobectomy and pneumonectomy are more common procedures for bleeding control in blunt thoracic trauma when resection is indicated. Question: what is the purpose of damage control thoracotomy in thoracic trauma? Answer: damage control thoracotomy may use laparotomy sponges and temporary closure over chest tubes to manage bleeding, but closure should allow for maximal lung expansion. Cardiac injuries. Question: how common and severe are cardiac injuries in cases of penetrating trauma? Answer: cardiac injuries are uncommon but severe, occurring in less than 1% of penetrating trauma cases. Question: what is the mortality rate for patients with cardiac injuries who reach a trauma center? Answer: the mortality rate for patients with cardiac injuries who reach a trauma center is high, ranging from 17% to 58%. Question: what trend has been observed regarding mortality in cases of cardiac injury with ballistic origins? Answer: both mortality and cases of cardiac injury with ballistic origins are increasing. Question: where are cardiac injuries most commonly located and how might they present? Answer: cardiac injuries are often located within the cardiac box and may present with pericardial tamponade or hemothorax. Question: what is a quick and effective method for assessing the pericardium for fluid in hemodynamically unstable patients? Answer: ultrasound is a quick and effective method for assessing the pericardium for fluid, especially in hemodynamically unstable patients. Question: how can the presence of blood in the pericardium be directly visualized and what procedures might follow? Answer: a subxiphoid pericardial window can be performed to directly visualize the pericardium and determine the presence of blood, potentially leading to a median sternotomy or placement of a pericardial drain. Question: what is the recommended treatment for cardiac injuries that cause cardiovascular collapse? Answer: cardiac injuries causing cardiovascular collapse are treated with a left anterolateral thoracotomy, which may be extended to a clamshell incision. Question: what surgical approach is often used for cardiac injuries and how are atrial and ventricular injuries repaired? Answer: median sternotomy is often used, with atrial injuries closed using Satinsky clamps and sutures, while ventricular injuries require more complex repair techniques. Question: what temporary measures can be used for closure during transport to the operating room in cases of cardiac injury? Answer: skin staples or a Foley catheter balloon can be used for temporary closure during transport to the operating room. Thoracic aortic injuries. Question: what is the mortality rate associated with thoracic aortic injuries? Answer: thoracic aortic injuries have a high mortality rate, with 80% of patients dying before reaching the hospital and 50% of survivors dying within 24 hours. Question: what is the primary cause of thoracic aortic injuries? Answer: thoracic aortic injuries are primarily caused by rapid deceleration, which leads to tearing of the aortic wall, most often near the ligamentum arteriosum. Question: what types of injuries may occur to the thoracic aorta? Answer: injuries to the thoracic aorta may range from intimal tears to full-thickness transections, with full-thickness injuries often requiring containment by surrounding tissues for survival. Question: what are the limitations of chest radiography in diagnosing thoracic aortic injury? Answer: chest radiography has a high rate of missed injuries in high-energy trauma, leading to the use of helical computed tomography angiography for aortic injury evaluation. Question: what imaging method is preferred for evaluating aortic injury? Answer: helical computed tomography angiography is preferred for evaluating aortic injury, which may range from intimal disruption to rupture. Question: is multidetector computed tomography angiography sufficient for operative planning in thoracic aortic injury? Answer: multidetector computed tomography angiography is usually sufficient for planning operative repair and often replaces the need for standard angiography. Question: what is the initial treatment priority for blunt thoracic aortic injury? Answer: the initial treatment priority for blunt thoracic aortic injury is to control aortic wall stress with beta receptor antagonists to maintain systolic blood pressure below 100 mm of mercury and heart rate below 100 beats per minute. Question: what is the preferred treatment modality for higher grade thoracic aortic injuries? Answer: endovascular repair is the preferred treatment for higher grade thoracic aortic injuries and offers mortality rates equivalent to open repair. Question: how are patients managed after treatment for thoracic aortic injury? Answer: after treatment, patients receive beta blocker therapy and follow-up imaging to monitor for expansion and ensure injury resolution. Question: what is the surgical approach for open repair of thoracic aortic injury? Answer: open surgical repair involves a left thoracotomy to expose the aorta. Question: how are large thoracic aortic injuries repaired? Answer: large thoracic aortic injuries often require replacement of the damaged aorta segment with a prosthetic graft. Question: what is the purpose of cardiopulmonary bypass during aortic repair? Answer: cardiopulmonary bypass is employed to minimize the risk of paraplegia by maintaining blood flow during aortic repair. Tracheobronchial injuries. Question: how common are tracheobronchial tree injuries and what is their clinical significance? Answer. Tracheobronchial tree injuries are uncommon but are associated with significant morbidity and mortality. Question. What are the most common causes of tracheobronchial injuries? Answer. Penetrating mechanisms are the most common cause of tracheobronchial injuries, while blunt injuries are less common and result from high-energy impacts to the chest. Question. What mechanism can lead to tracheal rupture? Answer. Rapid compression of the lungs and airways against a closed glottis can cause tracheal rupture along the membranous portion of the trachea. Question. What determines the clinical presentation and identification of airway disruption? Answer. The location of the airway disruption determines the clinical presentation and how the injury is identified. Question. What are the clinical findings of injuries to the thoracic trachea and proximal bronchi? Answer. Injuries to the thoracic trachea and proximal bronchi may cause pneumomediastinum, which can be identified on chest radiography or computed tomography imaging. Question. What is the typical outcome of distal airway injuries and how are they treated? Answer. Distal airway injuries typically result in pneumothorax, which is treated with tube thoracostomy. Question. What is the priority in airway management for tracheobronchial injuries? Answer. The priority in airway management is to control the airway and avoid further disruption, potentially using bronchoscopic guidance. Question. What does operative management of tracheobronchial injuries involve? Answer. Operative management involves thoracotomy, debridement, closure with sutures, and possible coverage with a tissue flap. Question. What are some considerations for postoperative care following tracheobronchial repair? Answer. Postoperative care may include endotracheal tube positioning, dual lung ventilation, or extracorporeal life support to protect the repair. Esophageal injuries. Question. What are the most common mechanisms of esophageal injury? Answer. Penetrating injuries, such as from gunshot and stab wounds, are more common than blunt injuries. Question. What is the mortality rate associated with penetrating esophageal injuries and what contributes to it? Answer. The mortality rate ranges from 20% to 44%, primarily due to mediastinal sepsis and injury to nearby structures. Question. How do blunt esophageal injuries commonly occur? Answer. Blunt esophageal injuries usually result from a rapid increase in pressure within the esophagus during compression of the chest or abdomen, often causing a perforation in the distal segment. Question. What are the most effective diagnostic methods for esophageal injury? Answer. Contrast esophagography using water-soluble contrast followed by thin barium, as well as esophagoscopy, are the most effective diagnostic methods, with a sensitivity approaching 100%. Question. What imaging techniques can be used for diagnosing esophageal injury, especially in intubated patients? Answer. Helical computed tomography esophagography can be used as an alternative to fluoroscopic esophagram, particularly for intubated patients, and chest computed tomography can reveal the presence of air outside the esophageal lumen, indicating injury. Question. Why is it important to determine the location of an esophageal injury? Answer. Determining the location of the injury is crucial for planning the appropriate surgical approach. Question. What are the operative goals in the management of esophageal injuries? Answer. The operative goals are to close the esophageal defect in 2 layers and to provide adequate drainage. Question. What is the preferred surgical approach for upper and mid-thoracic versus lower esophageal injuries? Answer. The preferred approach is right posterolateral thoracotomy for injuries to the upper or mid-thoracic esophagus, and left thoracotomy for injuries to the lower esophagus. Question. What additional considerations should be taken during esophageal injury repair? Answer. The entire esophagus should be inspected for additional injuries, and a vascularized intercostal muscle flap may be considered to provide coverage for the repair. Question. What is the preferred surgical approach for injuries at the gastroesophageal junction? Answer. Laparotomy is the preferred surgical approach for injuries located at the gastroesophageal junction. Question. How is an esophageal injury typically repaired? Answer. The injury is closed in 1 or 2 layers, often using absorbable sutures for the mucosa and interrupted sutures for the muscle layer. Question. What are key postoperative care steps following esophageal injury repair? Answer. Key steps include wide drainage of the mediastinum and chest, decompression of the stomach, and establishing distal feeding access. Question. What are the treatment options for esophageal injuries, particularly those identified late? Answer. Primary repair is preferred, but salvage techniques such as T-tube repair, esophageal diversion, or stenting may be required for injuries identified at a late stage. Question. How often is esophagectomy with planned reconstruction required in trauma cases? Answer. Esophagectomy with planned reconstruction is rarely needed in the context of trauma. Question. What is known about the evaluation of esophageal stents in trauma patients? Answer. Data on the use and evaluation of esophageal stents, which are similar to airway stents, are limited. Diaphragmatic injuries. Question. What are the incidents and causes of traumatic diaphragmatic injuries? Answer. Traumatic diaphragmatic injuries are rare and are most often caused by penetrating trauma, accounting for 67% of cases, or by blunt force trauma, with motor vehicle accidents being a common cause of blunt trauma. Question. How do blunt and penetrating trauma differ in relation to diaphragmatic injuries? Answer. Blunt trauma requires higher energy and is associated with higher mortality than penetrating trauma because it is more likely to result in severe concomitant injuries. Question. What are the long-term complications of untreated diaphragmatic injuries? Answer. Untreated diaphragmatic injuries can lead to delayed morbidity, such as giant diaphragm hernias, which progressively enlarge and cause abdominal organs to herniate into the chest. Question. How are diaphragmatic injuries diagnosed? Answer. Diaphragmatic injuries are difficult to diagnose and require a high index of suspicion. Question. What imaging modalities are used to detect diaphragmatic injuries? Answer. Chest radiographs can reveal abdominal viscera in the chest with large left-sided injuries, while computed tomography scans can show abdominal viscera in the chest or abnormalities in the diaphragm. Question. How accurate are computed tomography scans for detecting diaphragmatic injuries? Answer. Computed tomography scans have sensitivities of up to 78% and specificities ranging from 72% to 100% for detecting diaphragmatic injuries, but diagnosis remains challenging, especially in cases involving stab wounds. Question. When is laparoscopy recommended for diaphragmatic injuries? Answer. Laparoscopy is recommended for diagnosing and treating penetrating diaphragmatic injuries, particularly in hemodynamically stable patients who do not have peritonitis. Question. Is laparoscopy preferred over over computed tomography alone for traumatic diaphragmatic injuries after penetrating trauma? Answer. Laparoscopy is preferred over computed tomography scan alone for detecting traumatic diaphragmatic injuries after penetrating trauma. Question. What is the role of laparoscopy in evaluating blunt diaphragmatic injuries? Answer. Laparoscopic evaluation is helpful when imaging suggests blunt diaphragmatic injuries, which are more difficult to detect. Question. How are diaphragmatic injuries repaired? Answer. Diaphragmatic injuries are repaired by debriding non-viable tissue and closing the defect, typically with a single layer of non-absorbable suture. Question. What is considered for repair in cases of large diaphragmatic defects? Answer. Reconstruction with prosthetic mesh may be considered in rare cases where there is large tissue loss. Question. How is peripheral detachment of the diaphragm repaired? Answer. Peripheral detachment is repaired by reinserting the injured tissue 1 or 2 interspaces superior to its original position. Injuries to the abdomen. Question. What percentage of patients sustained abdominal injuries according to the 2016 National Trauma Data Bank? And what was the case fatality rate? Answer. 11.7% of all patients in the 2016 National Trauma Data Bank sustained abdominal injuries, and the case fatality rate was 12.9%. Question. What are the main sources of morbidity and mortality in abdominal injuries? Answer. The main sources of morbidity and mortality in abdominal injuries are bleeding and visceral perforation with associated sepsis. Question. How does the initial evaluation of abdominal injuries vary, and what is a common priority? Answer. The initial evaluation of abdominal injuries varies based on the mechanism of injury, but a common priority is determining the presence or absence of ongoing hemorrhage. Blunt abdominal trauma evaluation. Question. How is ultrasound used in the rapid bedside evaluation of intra-abdominal hemorrhage after blunt trauma? Answer. Ultrasound is used for rapid bedside evaluation of intra-abdominal hemorrhage after blunt trauma by assessing the pericardium, hepatorenal fossa, sphenorenal fossa, and retrovesicular space. Question. What does the extended focused assessment with sonography for trauma include, and what are its advantages? Answer. The extended focused assessment with sonography for trauma includes lung views to detect hemothorax or pneumothorax, and it is advantageous for repeat assessments in patients with physiological decline. Question. What is the purpose of diagnostic peritoneal lavage and aspiration in abdominal trauma, and how is it performed? Answer. Diagnostic peritoneal lavage, largely replaced by aspiration, involves instilling fluid into the peritoneal cavity and analyzing it for blood or bile, which indicates intra-abdominal trauma. Question. What is the primary method for evaluating blunt trauma patients, and how does it guide management decisions? Answer. Computed tomography scan is the primary method for evaluating blunt trauma patients, as it provides detailed images of abdominal organs to assess injury severity and guide management decisions. Question. How do computed tomography scan findings support non-operative management of solid abdominal organ injuries? Answer. The development of non-operative management strategies for solid abdominal organ injuries is supported by computed tomography scan findings, considering the patient's physiological state and the presence of hemoperitoneum. Question. What must be considered when deciding to perform a whole-body computed tomography scan in hemodynamically unstable patients? Answer. The decision to proceed with a whole-body computed tomography scan in hemodynamically unstable patients requires careful consideration, weighing the benefits against the time required for the scan and the potential for obtaining definitive hemorrhage control. Question. What are the limitations of computed tomography scans in detecting abdominal injuries? Answer. Computed tomography scans are less sensitive for detecting hollow viscous injuries, particularly in the gastrointestinal tract. Question. What are the indicators of gastrointestinal tract injury in abdominal trauma? Answer. Indicators of gastrointestinal tract injury in abdominal trauma include bowel wall thickening, surrounding adipose tissue inflammation, or free intraperitoneal fluid. Question. What does unexplained free fluid in the abdomen often represent, and what is required in such cases? Answer. Unexplained free fluid in the abdomen often represents blood from a non-bleeding mesenteric tear, which requires careful consideration. Penetrating abdominal trauma evaluation. Question. How are abdominal gunshot wounds initially assessed? Answer. Abdominal gunshot wounds are initially assessed using radiopaque markers and plain radiographs to determine bullet trajectory and pneumoperitoneum. Question. What is the utility of focused assessment with sonography for trauma scan in abdominal gunshot wounds? Answer. While a positive focused assessment with sonography for trauma scan may indicate the need for abdominal exploration, it cannot rule out significant hemorrhage or other operative trauma. Question. How should abdominal gunshot wound patients be managed based on their condition? Answer. Patients in critical condition should be resuscitated before intubation. Those with stable vital signs may undergo a computed tomography scan for further injury assessment. Thoracoabdominal gunshot wounds necessitate chest evaluation for potential injuries. Question. When is immediate laparotomy required for abdominal trauma? Answer. Immediate laparotomy is required for hemodynamically unstable patients with abdominal stab wounds, peritonitis, or evisceration. Question. How is evaluation for peritoneal violation performed in unexaminable patients? Answer. In unexaminable patients, evaluation for peritoneal violation can be performed using local wound exploration, computed tomography, or diagnostic laparoscopy. Question. How does management of abdominal wounds differ based on wound location? Answer. Flank or back wounds require computed tomography imaging with intravenous contrast. Anterior wounds allow for local wound exploration, serial examinations, or diagnostic imaging. Question. What triggers an open surgical approach in abdominal trauma? Answer. An open surgical approach is triggered by the development of peritonitis, hemodynamic instability, significant decrease in hemoglobin level, or leukocytosis. Question. What is required for an open surgical approach in abdominal trauma, and why might it not be universally available? Answer. An open surgical approach requires close surveillance infrastructure, which may not be universally available. Question. How should thoracoabdominal stab wounds be evaluated? Answer. Thoracoabdominal stab wounds should be evaluated with chest X-ray for pneumothorax and pericardial ultrasound for effusion. Management. Question. What does a laparotomy procedure involve in the management of abdominal injuries? Answer. A laparotomy procedure involves systematic exploration of the abdomen to identify and repair injuries, starting from the xiphoid process to the pubic symphysis. necrosis. Question. How is hemorrhage controlled during abdominal surgery? Answer. Hemorrhage is controlled by either direct approach to known bleeding sources or temporary packing with laparotomy sponges for unknown sources. Question. What is the purpose of damage control in abdominal surgery, and when is it performed? Answer. Damage control is a shortened procedure involving temporary abdominal closure, performed when physiologic compromise occurs during the operation. Splenic injuries. Question. Which abdominal organs are most commonly injured in trauma? Answer. The spleen and the liver are the most commonly injured abdominal organs. Question. How is splenic injury managed? Answer. The management of splenic injury is based on patient physiology and injury grade, and can range from non-operative management to surgical exploration. Question. What are the mechanisms of splenic injury? Answer. Splenic injury is most often caused by blunt trauma, which results in compression and tearing, while penetrating trauma is less common. Question. What is the most useful study for diagnosing splenic injury? Answer. Abdominal computed tomography with intravenous contrast is the most valuable study for identifying and characterizing splenic injuries. Question. How does splenic injury appear on imaging studies? Answer. Splenic injury is characterized by disruptions in the normal splenic parenchyma, often accompanied by surrounding hematoma and free intra-abdominal blood. Question. How is active bleeding identified in splenic injury? Answer. Active bleeding is identified by visualizing the extravasation of contrast material, which indicates bleeding into the peritoneal space or the presence of a pseudoaneurysm. Question. What is the success rate of non-operative management for blunt splenic trauma in high-volume centers? Answer. Non-operative management has a success rate of approximately 90% for blunt splenic trauma in high-volume centers. Question. What are the advantages of non-operative management of splenic injury? Answer. Non-operative management leads to reductions in hospital costs, intra-abdominal complications, blood transfusions, non-therapeutic laparotomies, and mortality. Question. When is angioembolization considered for splenic injury and what are its risks? Answer. Angioembolization is used to address active extravasation or pseudoaneurysms, but a more conservative approach may provide similar success rates with fewer risks. Question. Are there clear risk factors for failure of non-operative management in splenic injury? Answer. There is no clear constellation of risk factors to identify patients who would benefit from prophylactic operative management. Question. Does delayed operative intervention increase complications or mortality in splenic injury? Answer. Previous studies demonstrate that delayed operative intervention does not increase complications or mortality. Question. How should patients with high-grade splenic injuries be managed? Answer. Patients with high-grade splenic injuries should receive intensive care monitoring and have a low threshold for surgical management if their condition deteriorates. Question. What is the recommended surgical approach for splenic injury? Answer. The recommended surgical approach is a midline incision for assessment and mobilization of the spleen. Question. How is the spleen mobilized during surgery? Answer. The spleen is mobilized by dividing the wide line of Tolt and the short gastric vessels for complete mobilization. Question. What care is necessary after splenectomy? Answer. Post-splenectomy care includes vaccination against encapsulated bacteria and monitoring for overwhelming post-splenectomy sepsis. Question. Are vaccines necessary after splenectomy? Answer. Vaccines are crucial after splenectomy. Question. Which bacteria do vaccines protect against following splenectomy? Answer. Vaccines protect against encapsulated bacteria such as Streptococcus pneumoniae, Neisseria meningitidis, and Haemophilus influenzae. Question. How can overwhelming post-splenectomy sepsis be prevented? Answer. Vaccines help prevent overwhelming post-splenectomy sepsis, which is a serious complication with a high mortality rate. Hepatic injuries. Question. What is the prevalence of liver injuries following blunt and penetrating trauma? Answer. Liver injuries are extremely common after blunt trauma, occurring in 22.2% of cases, and are the most frequently injured abdominal organ after penetrating trauma, with a prevalence of 26.1%. Question. What are the mechanisms of liver trauma? Answer. Blunt trauma causes liver injury through compression and shearing forces, while penetrating trauma results in direct laceration of the liver. Question. How have mortality and morbidity changed in the management of liver injuries? Answer. Mortality rates have decreased with evolving management practices for liver injuries, while morbidity now includes complications such as bleeding, biliary issues, fistula formation, infection, and hepatic necrosis. Question. How are liver injuries diagnosed in trauma patients? Answer. Liver injuries are often diagnosed during abdominal exploration in unstable patients with free fluid and are confirmed with computed tomography scans. Question. What imaging technique is used to assess liver injuries, and how is it performed? Answer. Computed tomography scan imaging is used to provide detailed images of liver injuries, employing contrast in 3 phases, non-contrast, arterial, and portal venous, in order to assess the type of hemorrhage. Question. What findings might a computed tomography scan reveal in cases of liver injury? Answer. Computed tomography scan findings may include hepatic parenchyma disruption, perihepatic blood, hemoperitoneum, and contrast extravasation, which indicates active bleeding. Question. How has treatment for liver trauma evolved? Answer. Treatment for liver trauma has shifted from aggressive surgical intervention to non-operative care, resulting in a reduction in in-hospital mortality rates. Question. What was the impact of shifting focus in liver trauma management? Answer. Shifting the focus to prioritizing bleeding management over biliary and septic complications led to decreased mortality in patients with liver trauma. Question. What is the preferred management approach for hemodynamically stable patients with blunt liver trauma? Answer. Non-operative management is the preferred approach for hemodynamically stable patients with blunt liver trauma, regardless of the severity of the injury. Question. How are different grades of liver injuries managed? Answer. The majority of grades I to III liver injuries are managed non-operatively, while 2/3 of grades IV and V typically require surgical intervention. Question. What is the reported mortality rate for resectional management of complex liver trauma? Answer. A review of resectional management for complex liver trauma reports a mortality rate of 9%. Question. What factors contribute to improved mortality rates in liver trauma management? Answer. Improved mortality rates are associated with early decision for major operation, effective intraoperative resuscitation techniques, and the involvement of senior surgical and subspecialty assistants. Question. How should stable liver trauma be managed in trauma patients? Answer. Non-operative management is the primary approach for hemodynamically stable patients with blunt or penetrating liver trauma. Question. When is angiography indicated in liver trauma cases? Answer. Angiography is indicated when imaging reveals parenchymal bleeding or the presence of a pseudoaneurysm. Question. What are the considerations and risks associated with angioembolization in liver trauma management? Answer. Angioembolization can improve success rates of non-operative management, but aggressive embolization may result in hepatic necrosis and abscess formation. The decision should be made collaboratively between the trauma surgeon and the interventional specialist. Question. What complications may arise from non-operative management of liver injuries? Answer. Complications of non-operative management include bile leaks, hemophilia, and liver abscesses. Question. How are complications such as abscess and biloma diagnosed and treated in liver trauma patients? Answer. Abscess and biloma are diagnosed using computed tomography or ultrasound imaging, and treated with percutaneous drainage. Bile leaks are managed with endoscopic retrograde cholangiopancreatography, while hemophilia is managed through angiography. Question. What are the management options for biliary ascites in patients with liver trauma? Answer. Management options for biliary ascites include percutaneous drainage, laparoscopy, or laparotomy. Question. When is operative management indicated for liver injuries? Answer. Operative management is indicated for unstable patients with signs of shock, peritoneal signs, a high injury severity score, or associated intra-abdominal trauma. Question. What is the recommended surgical approach for managing liver injuries? Answer. The recommended surgical approach includes midline laparotomy, perihepatic packing for temporary control of bleeding, and evaluation of liver injuries for appropriate management. Question. What techniques are used for managing liver injuries during surgery? Answer. Techniques for managing liver injuries include compression, topical hemostatic agents, suture hepatography, and mobilization of hepatic loads for improved exposure and packing. Question. What is the Pringle maneuver, and how is it used in liver trauma surgery? Answer. The Pringle maneuver is used to slow blood flow to the liver, facilitating visualization and control of bleeding during liver trauma surgery. Question. How does the Pringle maneuver help identify the source of hepatic bleeding? Answer. The Pringle maneuver helps differentiate between hepatic arterial or portal venous bleeding, which stops with clamping, and hepatic vein bleeding, which persists despite clamping. Question. How are liver lacerations managed during surgical intervention? Answer. Management of liver lacerations involves exploring the laceration, controlling bleeding vessels, debriding devitalized tissue, and potentially using omentum to promote healing. Question. How should non-bleeding liver injuries near the retrohepatic vena cava be managed? Answer. Non-bleeding liver injuries near the retrohepatic vena cava should be packed and not explored. Question. What is the recommended approach for repairing retrohepatic vena cava injuries? Answer. The best success rate for repairing retrohepatic vena cava injuries is achieved by preserving natural tamponade whenever possible. Question. What alternative techniques are available for repairing liver injuries and controlling bleeding? Answer. Alternative repair techniques include the use of an atriocaval shunt, venovenous extracorporeal membrane oxygenation, and bridge balloon to control bleeding and facilitate repair. Question. When is damage control surgery indicated for liver injuries? Answer. Damage control surgery is used for patients with liver injuries who have experienced physiological deterioration. Question. What does surgical intervention involve in the management of liver trauma? Answer. Surgical intervention in liver trauma involves controlling bleeding, packing the liver, and temporary abdominal closure. Question. How are patients managed after surgery for liver trauma? Answer. After surgery, patients are resuscitated in the intensive care unit to address hypothermia, coagulopathy, and acidosis before re-exploration and removal of packs. Gastric injuries. Question. What is the mortality rate associated with blunt gastric trauma, and what contributes to this outcome? Answer. The mortality rate for blunt gastric trauma is significant at 28.2%, often resulting from high energy mechanisms and associated injuries to other organs. Question. How does the mortality rate of penetrating gastric trauma compare to blunt trauma, and what are the typical consequences? Answer. Penetrating gastric trauma has a lower mortality rate of 2.2% compared to blunt trauma and often results in full thickness perforations and spillage of gastric contents. Question. What are the mechanisms by which blunt and penetrating trauma cause gastric injuries? Answer. Blunt trauma causes rupture of the stomach due to increased intraluminal pressure, while penetrating trauma leads to perforation. Question. How can gastric injuries be identified during clinical assessment? Answer. Gastric injuries can be identified by the presence of peritonitis, which often develops more rapidly than with small bowel perforation, and by the location of penetrating wounds that suggest gastric involvement. Question. What role do computed tomography scans play in diagnosing hollow viscous injuries, and what are their limitations? Answer. Computed tomography scans are commonly used to identify hollow viscous injuries, but their sensitivity ranges from 55% to 95% and specificity from 48% to 92%, relying mainly on secondary signs such as bowel wall thickening and free fluid. Question. What factors necessitate prompt surgical exploration in cases of suspected hollow viscous injury? Answer. A high suspicion of hollow viscous injury, based on multiple clinical and diagnostic factors, requires prompt surgical exploration due to the increased mortality risk associated with delayed surgery. Question. What is necessary when evaluating the stomach for injury during surgery? Answer. Evaluation of the stomach requires visualization of both the anterior and posterior walls, including the lesser sac, to ensure that injuries are not missed. Question. How is the repair of gastric injuries determined, and what techniques may be involved? Answer. The method of repairing gastric injuries depends on the extent of tissue loss and the location of the injury, with options ranging from evacuation of hematoma to full thickness repair using sutures or staples. Question. What surgical options are available for managing severe gastric injuries? Answer. Severe gastric injuries may require partial or total gastrectomy, which could be followed by reconstruction procedures such as Billroth 1, Billroth 2, or Roux-en-Y esophagojejunostomy. Duodenal injuries. Question. How common are duodenal injuries in abdominal trauma? Answer. Duodenal injuries are uncommon, accounting for less than 2% of abdominal trauma. Question. What is the primary cause of duodenal injuries? Answer. Duodenal injuries are primarily caused by penetrating trauma, such as gunshot wounds, because of the duodenum's retroperitoneal location. Question. What is the main cause of morbidity in duodenal injuries? Answer. Morbidity in duodenal injuries is often related to septic complications complications, especially when repair fails. Question: why can duodenal trauma, especially blunt injuries, be difficult to diagnose? Answer: duodenal trauma can be challenging to diagnose because the duodenum is located in the retroperitoneal space and physical examination findings are often subtle. Question: what imaging methods are most valuable for diagnosing duodenal injuries? Answer: abdominal computed tomography is the most valuable tool for diagnosis, with repeat imaging using oral contrast. Enhanced computed tomography or upper gastrointestinal fluoroscopy recommended for hemodynamically stable patients with suggestive findings. Question: what should be done if imaging shows duodenal perforation? Answer: any evidence of duodenal perforation on imaging requires immediate operative intervention, and a low threshold for surgical exploration is important due to the potential for false negative computed tomography results. Question: on what does the management of duodenal injuries depend? Answer: the management of duodenal injuries depends on the location and severity of the injury. Question: how should obstructing duodenal hematomas be treated? Answer: obstructing duodenal hematomas should be managed with gastric decompression, total parenteral nutrition, and reevaluation after 5 to 7 days. Question: when is surgical intervention necessary for duodenal injury-related obstruction? Answer: surgical intervention is warranted if the obstruction persists after 14 days to address possible perforation, stricture, or pancreatic injury. Question: what did the Pan American Trauma Society study reveal about operative duodenal injury repair? Answer: the retrospective study from the Pan American Trauma Society found that 98% of patients with operative duodenal injury were amenable to primary repair, including All American Association for the Surgery of Trauma grades. Question: what is the standard method for duodenal injury repair? Answer: primary repair is suitable for most duodenal injuries and involves debridement and attention-free closure. Question: what complex repair techniques may be necessary for certain duodenal injuries? Answer: resection and anastomosis or enteric bypass, with a Billroth-II or Roux-en-Y reconstruction, may be necessary for extensive injuries or those near the ampulla. Question: what additional considerations can aid in duodenal injury repair? Answer: omental reinforcement can be beneficial, while other procedures such as diverticulization or caloric exclusion are considered on a case-by-case basis. Pancreatic injuries. Question: what is the incidence of pancreatic injuries in abdominal trauma? Answer: the incidence of pancreatic injury in abdominal trauma is relatively low, ranging from 0.2% to 12%, and is more common with penetrating trauma. Question: how do morbidity and mortality change with the severity of pancreatic injury? Answer: morbidity and mortality increase with higher grades on the American Association for the Surgery of Trauma scale, particularly in cases involving ductal injury, which corresponds to grade 3. Question: what mechanisms can result in pancreatic injury? Answer: pancreatic injury can result from a direct laceration or blunt force trauma, often due to crushing of the pancreas between a rigid object and the spine. Question: why are pancreatic injuries difficult to identify? Answer: pancreatic injuries are difficult to identify due to the retroperitoneal location of the pancreas and the limitations of available imaging techniques. Question: what is the best imaging modality for detecting pancreatic injuries, and what are its limitations? Answer: three-dimensional imaging with intravenous contrast-enhanced abdominal computed tomography is considered the best modality for detecting pancreatic injuries, but it has inconsistent sensitivity and specificity for identifying parenchymal injury and ductal involvement. Question: what computed tomography scan findings are suggestive of pancreatic injury? Answer: findings suggestive of pancreatic injury on a computed tomography scan include malperfusion of the pancreatic parenchyma, the presence of surrounding fluid or hematoma, and stranding in the adjacent soft tissue. Question: what is the rate of missed pancreatic trauma on computed tomography scans? Answer: computed tomography scans may miss pancreatic injuries in approximately 15% of cases. Question: how reliable are serum amylase levels for diagnosing pancreatic trauma? Answer: elevated serum amylase levels, when measured more than 3 hours after injury, can suggest pancreatic trauma but lack specificity for diagnosis. Question: how can advanced imaging techniques help in the diagnosis and management of pancreatic injuries? Answer: endoscopic retrograde cholangiopancreatography or magnetic resonance cholangiopancreatography can improve diagnostic accuracy for suspected pancreatic injuries and assist in treatment planning. Question: what is considered the gold standard for managing pancreatic injuries involving the main pancreatic duct? Answer: operative exploration is the gold standard for management of pancreatic injuries that involve the main pancreatic duct. Question: how is the pancreas exposed during surgical exploration for injury? Answer: exposure of the pancreas during surgical exploration requires mobilizing the hepatic flexure, dividing the gastrocolic ligament, and performing a Coker maneuver for complete visualization. Question: what factors are assessed when evaluating a pancreatic injury? Answer: assessment of pancreatic injury involves evaluating the extent of parenchymal damage, the location of the injury, and the presence of ductal trauma. Question: what is the surgical approach for pancreatic ductal injuries to the left of the superior mesenteric vessels? Answer: distal pancreatectomy is used to manage pancreatic ductal injuries located to the left of the superior mesenteric vessels. Question: how is treatment for pancreatic head injury determined? Answer: treatment for pancreatic head injury depends on the extent of tissue destruction. Question: how should limited tissue destruction from pancreatic head injury be managed? Answer: limited tissue destruction in pancreatic head injury can be managed with drainage, which may result in a controlled fistula that often closes spontaneously. Biliary decompression via endoscopic retrograde cholangiopancreatography stenting can help achieve closure. Question: what surgical procedure is indicated for massive destruction of the pancreatic head or combined pancreatic and duodenal injuries? Answer: massive destruction of the pancreatic head or combined pancreatic and duodenal injuries may require a pancreaticoduodenectomy, also known as the Whipple procedure, which is a complex operation with a high complication rate and is typically reserved for patients with stabilized physiology. Question: what is important in the management of pancreatic injuries to prevent complications? Answer: effective external drainage is crucial in the management of pancreatic injuries to divert pancreatic enzymes and prevent complications. Question: what is the recommended management for less severe pancreatic injuries that do not involve the pancreatic duct? Answer: grades 1 and 2 pancreatic injuries, which do not involve the pancreatic duct, should be managed with external drainage, pressure preferably using closed suction systems. Question: how can distal feeding access benefit patients with pancreatic injuries? Answer: distal feeding access may be beneficial for providing early enteral nutrition, depending on the patient's overall condition. Small bowel injuries. Question: how common is small intestine injury from blunt trauma, and what is the main cause of death in these cases? Answer: small intestine injury from blunt force is rare, occurring in only 0.3% of cases, and most deaths, approximately 15 to 20%, are due to associated vascular injuries. Question: what types of injuries can blunt trauma cause to the small intestine? Answer: blunt trauma can cause crushing injuries, rupture resulting from a sudden increase in pressure, or shearing injuries to the small intestine. Question: what can be the consequences of mesenteric injuries? Answer: mesenteric injuries can result in loss of blood supply to the intestine, leading to tissue death, even without direct damage to the intestinal wall. Question: how are small bowel injuries most often identified? Answer: small bowel injuries are most often identified during surgical exploration of the abdomen. Question: what symptoms may patients with small bowel injury present with? Answer: patients with small bowel injuries may present with peritonitis or worsening abdominal symptoms. Question: what are the challenges in evaluating small bowel injuries, and how effective is computed tomography imaging? Answer: evaluation of small bowel injuries is challenging and similar to injuries of the stomach and duodenum, with computed tomography imaging having limitations in accurately detecting these injuries. Question: what determines the type of repair for small bowel injuries? Answer: the type of repair for small bowel injuries depends on the extent of damage to the intestinal wall. Question: what repair techniques are used for small bowel injuries? Answer: small perforations are repaired using primary closure, while larger injuries or multiple perforations are managed by resection of the affected segment and reconnection of the bowel ends. Question: how is the decision to resect in mesenteric or bucket handle injuries made? Answer: the decision to resect bowel in mesenteric or bucket handle injuries is based on the size of the defect and the appearance of the intestine, with resection performed even for small defects if there is suspicion of reduced blood flow. Question: what is the aim of damage control surgery in small bowel injuries? Answer: the aim of damage control surgery in small bowel injuries is to rapidly close perforations in order to control contamination of the abdominal cavity. Question: what does resection involve in the context of small bowel injury management? Answer: resection involves the removal of the injured segment of the small bowel, particularly in cases of large injuries. Question: when is delayed anastomosis performed following small bowel resection? Answer: delayed anastomosis, or reconnection of the intestine, is performed after the patient has been resuscitated and stabilized. Colon and rectal injuries. Question: how common are colon and rectal injuries following blunt abdominal trauma? Answer: colon and rectal injuries are rare after blunt abdominal trauma, accounting for only 0.3% of cases. Question: how are colon injuries classified? Answer: colon injuries are classified as destructive, such as greater than 50% circumference injury or complete transection, or non-destructive, such as hematomas and serosal tears. Question: what mechanisms can cause rectal injury? Answer: rectal injury can result from penetrating trauma, such as gunshot wounds, or from sharp bone fragments in severe pelvic fractures. Question: what is the clinical presentation of patients with colonic injuries? Answer: patients with colonic injuries may present with a wide range of physiological states, from stable to hemodynamically unstable. Question: how effective is abdominal computed tomography for detecting colonic injuries? Answer: abdominal computed tomography is limited in its ability to detect colonic injuries, but it can reveal colonic wall thickening, surrounding stranding or fluid, and the track of a penetrating mechanism. Question: is the routine use of enteral contrast necessary to improve computed tomography diagnostic yield for colonic injuries? Answer: some advocate for routine use of enteral contrast to improve computed tomography diagnostic yield, while others believe that equivalent results can be achieved without it. Question: is digital rectal examination alone sufficient to confirm rectal injury? Answer: digital rectal examination alone is insufficient to confirm rectal injury. Question: what role does computed tomography scan play in evaluating rectal injury? Answer: computed tomography scan is crucial for evaluating rectal injury, and negative results significantly reduce the likelihood of clinically relevant trauma. Question: when is rigid proctosigmoidoscopy valuable for rectal and distal sigmoid colon visualization? Answer: rigid proctosigmoidoscopy is valuable for visualizing the rectum and distal sigmoid colon, especially when the computed tomography scan is indeterminate or clinical concern persists. Question: what determines the operative repair approach for colon and rectal injuries? Answer: the operative repair approach depends on the presence of destructive injury and the patient's overall physiological status. Question: what was the historical approach to colon injury repair? Answer: historically, resection with colostomy creation was performed due to concerns about anastomotic dehiscence and sepsis. Question: what is the modern approach to colon injury management? Answer: the modern approach includes primary repair for non-destructive injuries, resection and anastomosis for destructive injuries in healthy patients, and diversion for destructive injuries in patients with comorbidities. Question: what is recommended during damage control laparotomy for colon injuries? Answer: resection of destructive colon injuries is recommended. Delayed primary anastomosis is preferred, with colostomy reserved for specific cases. Question: what do guidelines recommend for the management of colonic injuries? Answer: Western Trauma Association guidelines suggest ostomy creation in unstable patients, while Eastern Association for the Surgery of Trauma guidelines recommend primary anastomosis even in damage control laparotomy. Question: how are extraperitoneal rectal injuries managed? Answer: operative management with fecal diversion is often required for extraperitoneal rectal injuries. Routine presacral drainage is not advised. Rectal contrast enema can be used to assess wound healing. Abdominal great vessel injuries. Question: where are the major blood vessels of the abdomen primarily located? Answer: the major blood vessels of the abdomen are predominantly located within the retroperitoneum, with some larger vessels found in the intestinal mesenteries. Question: what makes the management of abdominal great vessel injuries challenging during surgery? Answer: massive blood loss can compromise visualization, making surgical management of abdominal great vessel injuries challenging. Question: what are the most common mechanisms of injury to the abdominal great vessels? Answer: abdominal great vessel injuries are primarily caused by penetrating trauma, while blunt trauma often results in retroperitoneal hematomas from pelvic fractures. Question: how are abdominal vascular injuries most commonly identified in trauma patients? Answer: abdominal vascular injuries are often identified during laparotomy for penetrating abdominal trauma and are frequently associated with significant blood loss and hemodynamic instability. Question: what imaging modality is useful for assessing stable penetrating injuries to the back involving abdominal vasculature? Answer: three-dimensional imaging, often computed tomography, is beneficial for identifying the injury path and potential involvement of adjacent structures in stable penetrating back injuries. Question: what is the optimal imaging technique for evaluating abdominal vasculature following blunt trauma? Answer: contrast-enhanced computed tomography is the optimal imaging technique for evaluating abdominal vasculature after blunt trauma if the patient's hemodynamics permit. Question: how is the retroperitoneum divided for surgical decision-making in cases of abdominal vascular injury? Answer: the retroperitoneum is divided into 3 zones for the purposes of surgical decision-making. Question: when is exploration of a zone 1 retroperitoneal hematoma required? Answer: exploration of a zone 1 retroperitoneal hematoma is required for both blunt and penetrating injuries due to the potential involvement of major vessels. Question: under what circumstances is exploration of a zone 2 retroperitoneal hematoma indicated? Answer: exploration of a zone 2 retroperitoneal hematoma is indicated for penetrating injuries and for expanding hematomas resulting from blunt trauma. Question: what surgical maneuver is used for exposure of infrarenal or right renal hilum vascular injuries? Answer: right medial visceral mobilization, known as the Caudal-Broche maneuver, is used and involves mobilizing the right colon and mesentery to expose the lower midline vascular structures. Question: what technique is employed for exposure of suprarenal or left renal hilum vascular injuries? Answer: left medial visceral mobilization, known as the Maddox maneuver, is used and involves dividing the peritoneum along the left side of the abdomen to retract the viscera and expose the superior retroperitoneal vasculature. Question: what treatment consideration exists for blunt abdominal vascular injuries in stable patients? Answer: endovascular therapy may be considered for hemodynamically stable individuals with blunt abdominal vascular injuries, depending on the nature of the injury. Genitourinary injuries. Question: what are the main organs included in the genitourinary system? Answer: the main organs included in the genitourinary system are the kidneys, ureters, bladder, and urethra. Question: what injuries can result from blunt trauma to genitourinary organs? Answer: blunt trauma to genitourinary organs can cause renal laceration or bladder rupture, potentially leading to bleeding or urine extravasation. Question: what is the effect of penetrating trauma on the genitourinary system? Answer: penetrating trauma can make all structures of the genitourinary system vulnerable, often resulting in urine extravasation. Injuries to the pelvis and extremities. Question: what are the most common trauma injuries to the body? Answer: the most common trauma injuries involve the musculoskeletal system. Question: what is the prevalence of orthopedic injuries in upper and lower extremities? Answer: upper extremity trauma occurs in 31.66% of cases and lower extremity trauma occurs in 40.09%, making them the most common. Question: what are the main causes of orthopedic injuries? Answer: orthopedic injuries are most commonly caused by falls and motor vehicle crashes. Question: what is a Morel-Lavallée lesion? Answer: a Morel-Lavallée lesion is a closed degloving injury that shears the skin and subcutaneous fat away from the underlying fascia. Question: what complications can arise from a Morel-Lavallée lesion? Answer: complications include hemorrhage, fluid sequestration, tissue necrosis, and infection. Question: what is the recommended treatment for a Morel-Lavallée lesion? Answer: treatment includes compression, drainage, debridement, antibiotics, tetanus prophylaxis, and early washout. Question: how should a suspected vascular injury be evaluated in the context of musculoskeletal trauma? Answer: clinical evidence of vascular injury requires further assessment through imaging or direct surgical exploration. Question: what is the preferred initial imaging modality for evaluating peripheral vascular injury? Answer: computed tomography angiography is the preferred initial imaging method for assessing peripheral vascular injury, surpassing conventional angiography. Question: when is conventional angiography required in the evaluation of vascular injuries? Answer: conventional angiography may be necessary if an injury is identified during the initial evaluation. Question: what is the recommended management approach for injuries to the pelvis and extremities involving vascular compromise? Answer: management requires a multidisciplinary approach involving trauma surgery, orthopedic surgery, and endovascular specialists. Question: what are the typical mechanisms of injury leading to pelvic and extremity trauma? Answer: injuries result from high-energy mechanisms such as motor vehicle crashes, falls from heights, and pedestrian accidents. Question: what is the recommended initial investigation for patients with hemodynamic instability and suspected pelvic injury? Answer: patients with shock require immediate pelvic radiography to evaluate for fractures, since any fracture can cause bleeding. Question: how should open book pelvic fractures be managed in the acute setting? Answer: open book pelvic fracture should be compressed with a binder or sheet to reduce pelvic volume and control bleeding. Question: what is the purpose of pelvic compression in the management of pelvic fractures? Answer: pelvic compression addresses venous bleeding and may require angiography and embolization to manage arterial bleeding. Question: what interventions are used for pelvic stabilization in trauma patients? Answer: external fixation or definitive repair is performed to maintain reduction and limit bleeding in pelvic injuries. Rehabilitation. Question: why is rehabilitation important for patients following injury? Answer: rehabilitation limits long-term morbidity of injury and helps restore functionality. Question: how does the duration of rehabilitation compare to the hospital phase of care? Answer: rehabilitation can be substantially longer than the hospital phase of care. Question: how common are non-fatal injuries that require rehabilitation? Answer: approximately 31 million non-fatal injuries occurred in 2013, many of which required rehabilitation. Question: when does rehabilitation typically begin after an injury, and why is early mobilization important? Answer: rehabilitation begins immediately after acute needs are met, and early mobilization is crucial to prevent deconditioning. Question: who are the members of the rehabilitation team, and what roles do they play? Answer: physical and occupational therapists initiate therapy, while case managers and social workers identify the required resources. Question: how can patients with specific conditions such as traumatic brain injuries or spinal cord injuries benefit from specialized rehabilitation? Answer: patients with conditions like traumatic brain injuries and spinal cord injuries may benefit from rehabilitation centers with specialized expertise. That's it. Thanks for tuning in. If you enjoy our content, please like, share and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.